So, how many of you all perform your own ultrasounds and try to have a look at the CT or MR films and guess what lesion that is? Any show of hands? How many of you practice ultrasound here? No, apart from the radiologist. So, okay, so I don't think this cozy group is doing much of ultrasound because in our institute they all try to all the time, but the word is try. So the thing is, today I'm going to try to give a little light onto certain diagnosis about how do you approach lesions in a non-cirrhotic liver. So the outset is that we start with a non-cirrhotic liver because in the cirrhotic liver changes the entire gamut of lesions that you can see. So, why do we really need to know about these lesions? Why do we start? Because we want to know what are the characteristic imaging features that enhances our diagnostic accuracy. We want to avoid unnecessary imaging and therapeutic interventions in patients who we can just do with a simple ultrasound or a follow-up as they come back to us every time for their lesion. Also, being tertiary centers, people come to us saying that, oh, I have a lesion, I think it's a tumor or it's a cancer. And you need to be very sure once you, especially us, when we get back to you, that, okay, this patient doesn't need follow-up. So it has to be, viable option for the patient as well. And of course, it gives you very, very good upper hand in management. So the Swedish group has come up with this algorithm. I don't know, many of you may have read about this, and it's different from the ASLD, the Parcel, and other groups in the fact that they have incorporated certain criteria from the EASL and from the ACR, which is American College of Radiology. And this is the algorithm that I think we could look at. And then I'm going to show you all the cases and examples and how similar they can be to this sort of an algorithm. So when you see a focal liver lesion and somebody who's doing ultrasound, which is the first modality, which is your baseline modality, you suspect a focal fat sparing or a fatty change or a cyst or a hemangioma. So we go with these four things: focal fatty infiltration or sparing, cyst or a hemangioma. Patient is asymptomatic, just come to you with an incidental finding, no risk factors, no follow-up. We don't want to image this lesion again, and I don't want to see this patient on CT or an MR scanner at all. What if this patient has some sort of a symptom or has a risk factor which may or may not be associated with the lesion? Patient comes to us. Many centers are doing contrast ultrasound. We are doing it regularly. I don't know how many of your centers are doing it, but then CUS is the best modality to use. It's cheap, it's convenient. With one vial, you can actually do 3 ultrasounds with an experienced radiologist. So if there is no available CUS, if the lesion is less than 1 centimeter, MR is the modality of choice because it's able to pick up, it's specific. If the lesion is more than 1 centimeter, you go in for either a CT or an MR, depending on the availability and the economics of the whole situation. Let's say this patient has got a contrast study done. If there is no enhancement at all, the patient is usually having a cyst, an abscess, hematoma, some necrosis. Here, if there are risk factors, this could be a necrotic lesion. I'll show you some examples of this. Further goes in for a CT or MR, and then that's how we manage. Supposing there is some sort of enhancement, if there is an ISO enhancement, which means it is closer to the liver, then this is either again a focal fatty sparing, no washout at all. So it's just a routine lesion, there is no washout, there is just a mild enhancement. If there's an enhancement with washout, any kind of enhancement with a washout, and I will show you what a washout looks like, it has to be further investigated. These could be malignant lesions, they could be HCC, hemangiomas, or benign or other lesions. And then this whole part of the lesions is, if there is a washout, then you further evaluate, follow up, or go in for staging. So like I said, the first premise of what we are going to see now are the non-cirrhotic lesions, and we're going to be able to divide them using our case studies into either benign lesions or malignant lesions, primary lesions or secondary lesions, or we will label them as miscellaneous and take them out to biopsy. So when we talk about benign focal lesions, which are the commonest lesions which we see on ultrasound, first modality, focal fatty sparing, cysts, hemangiomas, FNH, and hepatic adenomas. When I talk about these 6 lesions, after 5 lesions have pretty much covered all the benign lesions that we've ever seen. All of them can be easily seen in ultrasound and maximum on a contrast ultrasound. Few of these lesions like adenomas will need further evaluation, and for that, MR is the modality of choice. If you don't have an MR, a CT is a good enough choice to make. Now, anybody who can pick up, I've already marked it. So this area is a fatty sparing area. So when you see a fatty liver, that I think you all know is echogenic liver. So you see a brighter than normal liver, whom you compare it with either the kidney or the spleen. If it doesn't look the same, it is fat, it's brighter. And what area which is not fatty looks like a lesion. So this is a pseudo lesion, it's not a real lesion. Many a time patients have come to us saying that I have a lesion in my liver and I need a CT scan for that. So this is how we end up doing a CT. On a CT, it's the reverse. So the fatty liver is dark on CT, and this bright area that you see is the area which is spared of fat. So it reverses on CT, and it is different on dark on ultrasound and bright on CT. So this is a fatty liver, and this is a bright area which is spared. So most of these lesions are pseudo lesions. Every lesion that is bright on the in the liver is not always a fatty infiltration or a fatty area. So when it is well defined or it is playing or displacing vessels, then you have to know that this could be a mass lesion, even though it is echogenic, not hypoechoic, like you see some lesions. On a CT, this so-called bright lesion in the liver is completely necrotic. So this is a child where we only advocate a single or a dual phase CT. We don't ask for a triple phase CT in a child because invariably, if the lesion is enhancing in the liver, then it is either hepatoblastoma or a mesenchymal tumor for which you only need a palate. So you don't want to give too much radiation, and if the child is amenable to MR, then why not? So when you do a contrast study, so this is all the bright areas of contrast in the liver, and this is a punched out lesion in a patient who came to us with suspected cysts versus metastasis. So the known case of CF breast, some lesions in the liver, we don't know what that is. So if it is a completely punched out lesion and there is no peripheral vascularity with splaying of liver vessels, this is a simple cyst and nothing needs to be done about it. But in the same liver, there are other lesions which are marked here. That's a plain B mode, and that is a contrast study with contrast within the O2 vein. These are not completely punched out like the one you saw on the previous slide, and they're nothing but metastasis in the same liver. This is also a contrast study where the rest of the liver is dark. It's just that there's no color in it, it's just black and white. This lesion is completely filled with contrast. That's how it looks in B mode, and that's the pattern of the liver. This is a hemangioma where there is complete filling of the lesion. When you see such ring or target lesions, then you have to suspect metastasis. Look at the enhancement. This is only peripheral enhancement, and this is the pattern that we are looking at. So we could differentiate a cyst versus a metastasis in the same liver. What is the most common lesion that there is a problem with, which is a hemangioma versus a cyst? Because hemangiomas, I'm going to show you, can be of various varieties. Now, this is an MR study. This is a T1 MRI, and this is a hemangioma versus a cyst. Now, if I tell you this is less black than the rest and this is more black than the rest, it doesn't make sense to you, but it does make sense to the radiologist, which is why you need to consult a radiologist for such a study. If the lesion is as dark as a CSF, then it is a cyst. But if it is not dark enough as a CSF, it is usually not a cyst. So this is a hemangioma and this is a cyst. When we move on to a T2 weighted study, the lesion which is as bright as the CSF is a cyst, which is less bright than the CSF is a hemangioma here. What happens on a diffusion weighted study? The cyst is not going to show any restriction, so it's not bright enough. Whereas look at the hemangioma, it lights up like a light bulb on a diffusion weighted sequence. So all these sequences I know are a little foreign for you, but when you discuss them with your radiologist, you usually get used to the terminologies and how these lesions look, and you can even try a diagnostic testing for yourself. So this is a post-contrast study. This is a cyst, no enhancement at all, and here we have the classical hemangioma, peripheral nodular enhancement, and filling up. When I talked about washout, this is what I meant. What we say washout is when we compare it to the rest of the liver. So when nowadays we use a contrast-specific, MR contrast for liver in India, which is POPTA, only one available in India, you will see washed out areas on a 1 hour delayed scan because this is not a hepatocyte origin tumor, so it is not going to take up the entire contrast. But this, of course, is going to be completely punched out. It's effect in the rest of the enhanced liver on a delayed 1 hour study. But this lesion appears to be washed out, but actually this is a pseudo washout. This is a hemangioma, has taken up contrast, but it is not comparable to the rest of the hepatocyte filled liver, which is showing adequate enhancement. So this is what a pseudo washout would look like. This is not a malignant lesion. Now coming to various varieties of hemangiomas, a sclerosed hemangioma is a puzzle. It is bright, it looks like a cyst, but not bright enough. And this is where it is not showing you classical enhancement, just a teeny bit of nodularity at the periphery. This is another cavernous hemangioma which looks like a cyst, but it's actually a ruptured cavernous hemangioma and is ruptured into the thoracic cavity, and hence you are not seeing the enhancement that is classical to that. In the same liver, if you have multiple lesions, be very careful calling them all the same. This is a liver with cavernous hemangioma here, and look at these lesions which are enhanced and then washed out. This is a classical washout, this is a peripheral enhancement, and this is another hemangioma with a nodular enhancement. These were nothing but neuroendocrine tumors, and they were secondary to the liver, along with hemangiomas in the same liver. So be very careful to label all of them the same. This is a classical polycystic liver disease. So these are what the cysts would look like on an MR. A Carolee would also look like multiple cysts, but you have accompanying ADPKD here. And this is a classical central dotted sign. This is not a cyst. This is only a Carolee disease with these dilated channels and a central portovein radicle in the middle. You have an ultrasound to help you with doctor in that. So everything that looks like a cyst is not always a cyst. How do we know that? Because we take attenuation values inside the lesion, and this is nothing but an intrahepatic lipoma, although it looks like a cyst, because I have the attenuation of back to it. Now, hydatids, I know if they're classical, are very easy to diagnose. We see provolone calcification, we see cyst, but the key point here is that we have to look for complications and communication, like here with the bile duct. So MR is a modality of choice for hydatids because you can easily look at the biliary ducts communicating with the hydatid, and you can see these floating membranes within the liver. This lesion also could be, you could be confused with it with the hydatid, but this is not hydatid. This is a biliary cystadenoma. These are not floating membranes. In fact, these are septations within the liver. And here is a stent that has been placed, and that is the MR classical picture of a biliary cystadenoma with enhancing septations within this exophytic lesion. What do you think this is? This patient has come to us with a PCB tip inside the lesion, thinking that this is an abscess, comes from the periphery. But I know that this is not an abscess the minute I look at it, because there is enhancement on the periphery, there is no peripheral edema in the liver, and there is a huge mass effect. I don't see the vessels, and obviously this turns out to be a necrotic NCC, which is mimicking a liver abscess. So visceral larva migrans, again patient comes to us with multiple little cysts clustered in a corner, and then I see this picture and I ask for an AEC count, and lo and behold we get a large absolutely simple count and a small FNAC can clear the doubt of a cyst. So all these are cystic looking structures, but they're not really cysts. So here is this dilated radicle because they're elongated, they're dilated, and there's one sector. You know that this is nothing but a RBC. And here is another patient with dilated channels, but this is not a cholangular abscess because we have these dilated bile ducts and we have smaller lesions with it which look like abscesses, but they don't have a halo, which I usually see with evolving cholangular abscess. And when we biopsy this, the FNAC this, we get AFB within these lesions. This is a tubercular multiple liver abscess. Usually we will see tuberculosis like this. We will see multiple cystic looking lesions, but they're not cystic, they're granulomas and they're hypodense of the liver. So every time we look at lesions, we will look at their attenuation values. Now this is a classical FNH or a fibronodular hyperplasia. These are all MR images, T2, T1 and diffusion, but what we have to look at is the enhancement and a small central scar. And if you can see and appreciate this, is a little spoke wheel pattern, and that's what makes this a classical FNH. This is an adenoma in a young male. This is telangiectatic, now known as an inflammatory adenoma. And you see all these large pleiotic spaces within it on a plain study. And here we go and look at the contrast study and look at how the necrotic areas are shining through, and the rest of the liver is, the rest of the lesion is well encapsulated. Now, adenomas, I'm sure you know the management. Any size adenoma in a male patient goes for resection. And in female, we need to look at the MRI after repeating it every 6 months. If it is less than 5 centimeters, let it be stable. If it is more than 5 centimeters, it goes for resection. And then after 6 months, it can go to an annual follow-up. Does this look like an adenoma too? Yes, it has fat within it, it has enhancement within it. And we also thought it could be, but when you see solitary lesions in a non-cirrhotic liver, they always need to be biopsied, and that is a dictum even for hepatocellular carcinomas. Few more cases and I'm going to be done with the lesions. So this is again another solitary lesion, peripheral enhancement. Here we see on MR and CT the same picture. We thought this is an HCC too, but no slides were made available for review. Patient underwent a resection and comes back the result that this is an NET, neuroendocrine metastasis, a solitary metastasis, which we published. And then we did a daughter knock PET and we found a little lesion in the intestine. So I suggest that whenever we look at lesions in the liver, we must always do a complete abdomen study and a chest study also if we need to. Similar looking lesions, they all look the same, but there are many features like septations or the age group and how the pattern is that needs to be looked into deeply. Spoke wheel pattern, very classical of fibrolaminar carcinoma, which is similar to an HCC. It's a young male patient, necrotic in the center, spoke wheel pattern, and you can demonstrate the vascularity beautifully. And the last case, which I'll leave open to the audience. So what we learned just now, can anybody attempt for this? See, you think this is a liver lesion? Yes. You don't lose marks. Just say yes. This is a liver lesion, right? Is this enhancing on contrast? Yes. Is there a washout? Yes. Very good. So there is a washout, there is a central scar, and there is enhancement. Do you think this could be HCC? Yes. So we also thought this could be HCC. You're damn right about it. And there were multiple nodes in the chest as well. So we gave the diagnosis in HCC. And here comes the diagnosis. This is nothing but a spindle cell sarcoma of the IVC invading into the liver. And then when we looked at the MPRs and we saw that there was a slight cleavage plane between the sarcoma and the liver. So this is a very commonly made mistake. But these are all small things that are going to happen all the time, but we need to make a diagnosis with whatever is available to us and always be careful about the fact that it will always be wrong and we learn every day. Thank you.
Thank you so much, Dr. Shalini. That was an extensive talk. Beautiful.
That was the idea for the students.
No, actually, we don't get to see everything. Very elaborative talk, but then very nicely presented. Thank you so much for that. Just one question. I just have one question. Regarding the role of elastography, always in elastography for preventing patients, and also as a follow-up post-treatment. Have you been doing what is the role of?
So yes, elastography is a well-documented modality, but what would you want to really use it for without, once you've diagnosed lesion, unless you want to follow up a change in malignancy? Yes, so adenomas, once they're diagnosed on an MR, following up on them up on elastography is something that I would not recommend, because if it is turning malignant, there is no way that it turns so malignant and the elastography value goes down, which is what happens with the malignancy. You don't want to wait for that. Like I said, so if there is a change in size or there is a change in characteristics, which only a contrast study can tell you, there is no point of using it.
So you would use it in practice. Let's say you don't want to spend money on
I would spend it on diagnosis, but I would not, and especially cases where there are children or there are patients with renal issues, which we do get a lot in liver patients. So the niche for contrast ultrasound I feel with liver patients is the fact that they have both kidney and liver disease and they don't want to get a CT done. That is where this modality is just excellent. Or for children where it's not documented, but let's say 18 and 22, or who are on follow-ups for other lesions, or EHPV or other such things. But to follow up a potentially benign versus malignant lesion, to follow up the change from benign to malignant, I would not have.
So for diagnosis, for diagnostic purposes, let's say you want to differentiate between inflammation and is that useful?
It is useful, but eventually it's the enhancement pattern of practice, because that's the tissue, the viability that you want to see. So it is an add-on, but it is not the end all. Yes.
Short question. The first slide you put a CS as a initial imaging modality after the ultrasound. In the real world practices, you have to go for an see a lesion, focal evaluation, whether we offer a CT or not. How do you actually do CS in the real world practice?
Yeah, so real world.
Absolutely.
So I'm a big advocate for CUS, although my favorite is MR. MR is so much easier for us to see. But if you look at the real world scenario, actually CUS is a very pocket friendly and a very good modality with an experienced radiologist. And with one vial, the more you get experience with it, with one vial of 5 ml of fluid, I can actually scan 3 patients. So it's a 6,000 vial. I use it for 2,000 rupees, and then I just charge a little bit for the ultrasound. So in a 2,500 rupees study, you can easily scan the patient and see whether what ma'am was saying, that if the lesion is increased in size or there's a change in enhancement pattern or there is something happening there. And now we even have sonazole. We brought with research agreement. We have sonazole. So it's a very good modality to screen and for surveillance. Well, it has to be with an experienced person, right? And we do it with the same person that is experienced. That's what every well, it is not subjective actually. It's just experience of the same data. It's not subjective. When I check patterns, then we have the Lyra also. So yeah, yeah, it's not meant for the voice. It's meant for the radiology.